it's my pleasure to introduce Professor Bhramar Mukherjee, who's the, I'm going to say this badly, the John D. Kalbfleisch Collegiate Professor. Nice, thank you. And also chair of the Department of Biostatistics, as well as she's also a professor in the Department of Epidemiology at the School of Public Health. And she's a highly accomplished statistician and data scientist and has been doing just remarkable work modeling COVID-19 in India to inform policy and guide decision-making, which I'm really looking forward to hearing about this morning. And so I'll keep my introduction short and just pass it to you, Bhramar.
Thank you so much, Marisa, and thanks to you, Emily, and all the other organizers for giving me this opportunity. It is really an absolute honor and pleasure to present the very first talk in this tremendously significant symposium, highlighting the contribution of data scientists and modelers to the COVID-19 pandemic. I am here to present the work by a group of us on modeling the SARS-CoV-2's transmission dynamics in India. I always say that I am a data dreamer, but I'm not the only one. I was fortunate to have these data warriors shown on this slide committed to making a difference with data. This work was truly our escape from the early days of pandemic gloom last year in 2020, trying to compute our way out of this pandemic. So together, we built this app, COVID-19.org, for daily tracking of the pandemic in India. For example, if you connected to the app a couple of days ago, you'll land on this snapshot table where you are going to see the information on the rise of cases and deaths in India over the last 1 month. It's truly astonishing. You'll also have information about the number of tests, vaccinations, and many other epidemiologic metrics which help India and the policymakers to evaluate the growth and the transmission of the pandemic. Since we have been engaged in this work for nearly 400 days now, I want to structure today's narrative into 2 halves. I'll first talk about wave 1 and pre and post lockdown phase, followed by a discussion of wave 2 and where we actually stand now. So before I begin, I have to define wave 1 and wave 2. So let me give you a snapshot of what happened in India. The first national lockdown in India was very early, and that was between March 24 to May 31. That was a 6-week lockdown. And you can see that the virus curve peaked in September with about 98,000 cases per day, and then went down steadily until in February, it started showing an uptick again. And the second wave has been much, much higher, registering 4 times more reported cases in India than wave 1 peak. And also the healthcare system has completely crumbled, leading to a rise in the number of deaths as well. So when I define wave 1 and wave 2, I'm going to take a very mathematical definition of it, and if people can argue, I'll define wave 2 to be starting on Valentine's Day, February 14, 2021, when we first saw that after the effective reproduction curve staying below unity for a long time, it crossed 1 again. And you can see this is the part where we are seeing, like, it was went up to 1.6 at one point of time, and then it's coming down again. So just to give you a summary, India is reporting about 20 million cases so far throughout this whole time, about 222,000 deaths. Current daily test positive rate is at 22%, percentage fully vaccinated 2%, and percentage vaccinated with 1 dose is 10.5%. The case fatality rate in India has been lower than the Western world. In many other countries, it is 1.1% right now, cumulative. So when we talk about India, when I show this curve, it is really not fair, because India is a nation, many nations within a nation, and there's tremendous heterogeneity across the different Indian states and union territories. So where India is now registering about 350 to 400,000 new cases and 3,000 to 4,000 deaths every day, the different states are actually have a lot of variation. So we have to acknowledge that heterogeneity across states when we model this pandemic. And our app actually provides a snapshot, a point in time evaluation of the different states in terms of daily new cases, daily new deaths, 7-day average TPR, case fatality rate, R, and so on. So this has been very helpful for policymakers to take as a one-page summary, and we have had many visits to the app. And I'd like to say that building this app has been the main contribution of this work. We have written papers, but I think in terms of public engagement and everyday updating, this app has been the truly remarkable contribution. And the University of Michigan School of Public Health students have made a difference with data in this case. So when we started modeling this pandemic, India had only 536 cases total and 11 deaths. If you cannot believe the y-axis of this graph, this is really true. There are 30 to 40 daily cases when we started modeling this pandemic. And it was started during the stay-at-home order in Michigan, when all of us were feeling lost and wanted to find some way to contribute. So we were worried about India. India has some advantages in terms of a very young population with mean age of 27 years and 40% of the population being in the age group of 0 to 18. But India also has a very fragile healthcare infrastructure. For example, the number of hospital beds per 1,000 people in India is 0.5, compared to that to the US number, which is around 3. It also has a large number of uninsured people and people with comorbidities, which have been associated with the COVID-19 severe outcomes. So when we first predicted, we chose a very different outlet to release our work. We published a paper, an article, and a report in Medium because there was no time. And we said that, yes, in March of 2020, we are standing at 500 cases, but exponential growth can lead us to 58,000 cases by March, which seems so, by May, which is so minuscule right now. We also talked about the confidence interval and prediction intervals. Uncertainty in terms of prediction has been highly ignored. Sometimes in this pandemic, you only see point estimates. I also realized that journalists really like the upper credible interval and the policymakers like the lower credible interval when you put forward a prediction. So we compared India with US and Italy and showed that, the things actually grew like that very silently and then exploded. So little idea did we have that one Medium article and the report, which was on our center's website, not even a peer-reviewed publication, will create so much impact. And the media really picked it up, and the news was all over the world. And our projections, which were updated every day, were quoted as one of the critical pieces of evidence governing India's policy at the time. So soon after that, on March 24th, came India's very controversial decision to have a national lockdown. And the implementation of the lockdown with little preparedness and little time unfolded human tragedy when the migrant workers started going back to their home and there was no transportation and many lost lives. So in India, the battle between lives and livelihoods is even harder in terms of economic stimulus, and I'm not going to talk about that. But the national lockdown, there are many social ramifications as well. On the right-hand side of this slide, you can see that people are lighting lights or lamps all over the country in order to eliminate the darkness due to COVID. So the national lockdown happened and India had successes. I want to show you that social distancing and quarantining in India with a high population of 1.38 billion people and densely populated slums in some cities is not so easy. But I think in India tried their best. You can see this is a snapshot from Dharavi, Mumbai, Asia's largest slum, where women are having face covering and they don't have as many tests accessible. So healthcare workers are doing syndromic surveillance and temperature checking. So in wave one, India really tried to scale up healthcare infrastructure, surveillance, and and did reasonably well, which was probably contributed to the complacency in wave 2. What models did we use when we actually published that Medium article? We did not have time. So we actually took a model that Marissa and Peter Song lab had in biostatistics had worked on, which is an extension of the SIR model. I know that many people in this audience know SIR model. It has become the linear regression of the 2020. So it was a very simple structure that we used, and we didn't have time to develop models and methods at the time. So we had 3 compartments: susceptible, infected, and removed. The removed had the recoveries and the deaths together. And the challenge is that you did with these models is that you have a true number of latent infections, and some of them get identified as cases, hospitalizations and deaths, but there is this tip of this epidemiologic iceberg that you only see. The true proportions in each of these compartments are actually unknown. So Peter cleverly formed a latent process model where at each time point t or a day t, you think about these proportions in each of these compartments as a true parameter theta, and then conditional on that, you actually get to see the observed time series, which is reported, which are the ascertained cases and the recoveries and the deaths that are reported. So then what you, and if you're interested in this model, you can look at the paper by Lily Wang, and Peter's lab has this package in RCRAN available as well. So we had to use an off-the-shelf good method, which was used actually to model the trajectory in Wuhan. And and all of us know these models are very unusual for statisticians. So I had a lot of fun learning about these compartmental models throughout this last 1 year, where we start with y equal to x beta. That's our sort of standard modus operandi. But here we have a set of differential equations describing the transmission dynamics through a transmission parameter, through a removal parameter, and a set of engine which is emitting this process. And the differential equations were actually written in terms of the true latent parameters, but then the only novelty in terms of this formulation was the observed data was modeled conditional on the latent parameters, generating a hierarchical structure with the beta Dirichlet formulation. And with the removal rate parameter and the transmission parameter, you can also write down the effective reproduction number, which has become very popular. And that's what I was showing you to model the trajectory. And to correlate day t with t minus 1, that's where a Dirichlet distribution was assumed to impose the autocorrelation. So you basically generate this system of time series, and standing at time t, you want to forecast what is coming in the next 2 weeks or the next 4 weeks. So what we did was to set up a Markov chain Monte Carlo algorithm where we are going to get not just the estimate of these parameters, but also the complete posterior distribution so that we can characterize the uncertainty of these parameters. And not only the parameters, the final ultimate objective is to actually predict the counts, that how many cases are you going to see, how many infections are you going to see, and also daily estimates of future daily incidence curves. When is the India going to peak? When is it going to, the outbreak is going to end? All kinds of quantities that the policymakers are interested in. And in terms of modeling intervention, what this model does is to really introduce a intervention modifier schedule, or pi of t, which can change with time. And the goal of this is, as you introduce mandatory face covering or lockdowns or social distancing, travel bans, this is supposed to reduce the probability of movement from the susceptible to infectious compartment. And you can rewrite this differential equation introducing this pi t, and now we have enough data to even data adaptively estimating the effect of different interventions. And so what we were doing for the government was actually projecting how long should the lockdown last, and also what should be the exit strategy from the lockdown. So we are producing curves like this, daily incident curves, that if you came back in June with a very cautious return, what will happen? If you came back like in an overzealous way, you can negate the effect of lockdowns. So these graphs actually corresponded to different pi schedules, or how this transmission probability is going to change. So quickly we realized that updating or calibrating the model is very important. It's not like another academic paper where you leave it and then you come back when the reviewer responses come back in 6 months. We had to really update it. So that's why we started updating the app every day. Let me show you that why I think this is important. So this is India's capital, national capital, Delhi, and I want to start from last June and just show you how Delhi changes over time. So if I did not really capture this real time, this will be really difficult. And so right now, this is where Delhi stands. And there is this damped oscillatory behavior in terms of growth and decay that we really have to model. So then, after this initial use of the ESIR model, just like a modeler, you start getting unhappy with everything that you have done with your analysis, and you want to do a little bit more. So then we started working on a model which is a more has more compartments, more complex. And as the pandemic evolved, we had more data and more information to identify some of the parameters and some of the compartments, where we had an extension to the SEIR model, but we incorporated that this diagnostic tests for SARS-CoV-2 were highly imperfect sometimes, and they could have false negatives. So we incorporate compartments for the test results to be false negative. Then you go back as if you were not an infected person. And so we also introduced latent compartments for undetected cases and unreported deaths. And that led us to a bit more of granularity in terms of getting at the true infection fatality rate as opposed to the case fatality rate, that as a statistician, I almost feel like I'm committing a sin when I'm putting all of these case counts from different states and different countries on the same slide, because everybody has a different testing criteria and different resources for testing. So using this model, in order to understand that testing and ascertainment bias, we could actually come up with estimates of the infection fatality rates, which in India lied between 0.1 to 0.4%, depending on whether you believe the observed data or you want to actually account for underreporting. And there's a lot of heterogeneity across Indian states that you can see. And we estimated an underreporting factor for cases between 10 to 20 in all of our work for 400 days, and for deaths from 2 to 5. And here in this particular snapshot, you see that they are 11 and 3. And so I'm mentioning this because this created a lot of news about this underreporting of cases and death counts in India, and we can talk more about that. So I would like to then talk about, like the last 5 minutes, I want to talk about India's astronomic wave 2. And here you can see I have plotted Brazil, India, and US, the 3 countries which register the highest number of cases in the world. And we can see that why did it happen? So I showed you the first curve, that the curve stayed below, like, very quiet and calm till February. And then at the same time, the country reopened and there were massive weddings happening, the relaxation of travel bans, and completely abandoned little or no mask use. And people were and the policymakers and everybody felt that there was some sense of exceptionalism. And even people were delaying vaccination because there were no sense of imminent threat of the virus. And so this human behavior is, of course, responsible, but at the same time, there are many super spreader events in terms of, I'll show you some pictures of massive religious gatherings, election campaigns that really added fuel to the fire. On top of everything, the new variants of concern that were circulating all over the world took their own form and shape, with many new variants emerging into the Indian landscape. So this was a perfect storm creating this virus inferno. And you can see, I showed you the behavior of the public during wave 1 with 500 cases and 11 deaths. And this is the behavior when the case counts are going up, 3 states are showing uptick. There is massive unmasked rallies and this taking a bath in a holy river. So is this unexpected? And of course, like, there are many cautions, and scientists really caution the government from when they started seeing this uptick. And if you go back in history, if you look at the second surges, this is a graph figure taken from a history book. And this is 1918 influenza pandemic in India, which was massive in India. And you see essentially the same pattern. And you can see that the second surge is much more tall and skinny. And Mumbai, which is the gateway to India, which gets always hit hard first because of the imported cases. So this was to be expected, but the preparedness and people threw caution to the wind, which has led to a very grim prediction for India. Here, there are many models that we have run, and every model shows that the number of infections are going to peak in the first half of May, but the number of deaths, which are lagged factors, and I do not want to look at these predictors because this is the Imperial College model, the IHME model, our model, all are saying a large number of deaths happening in the month of May. So, moving forward, I think as summary, I want to say that what I learned from the modeling exercise is that models are models and they're wrinkled with assumption. And if any single model claims to be the best forecaster, there is something audacious about it, something impossible about it. Right now, the situation is so challenging because you have to model not only the virus transmission process through this epidemiologic model, but the human behavior process, the virus mutation process, you need information about reinfection, cross-immunity, and how vaccination is going in India. So we need a massive team together and lots of information in order to model this process, highly complex process correctly right now. So moving forward from policy perspective, I think that India is the magnet for vaccine production, but the start to the vaccination plan has been really sluggish. And experts have recommended about 10 million doses per day to vaccinate adult population in 6 months, but India has been doing only about 3 million doses per day. We really need to keep handle on the pandemic through data, and I particularly feel that India's data deficient infrastructure has really hurt us. Sero surveys are very important for India to do, genomic sequencing with epidemiologic surveillance with all of these variants circulating, and also historical data so that people can actually do a proper calculation of excess mortality in 2020 and 2021. We also we hear these anecdotes that younger people are very, very highly affected in wave 2, but we need more granular data in terms of age and sex and individual characteristics for hospitalization and deaths for India. And I really worry with so many people being infected, the health of the next generation of citizens of India in terms of long COVID and post-COVID sequelae. Finally, I think that public has a serious role to play in public health. We have learned that, and we all need to manage our risks. And this whole process of fighting this battle, and many of you know I'm not an infectious disease modeler, but somehow I jumped into this process and it's like too hard to back out right now. And I became an activist. And I became almost like writing columns, talking to media, emphasizing the need for global collaboration. Somewhere, I was not just a statistician. These numbers were not just numbers. These were people. These were faces of loved ones, people that we have lost in the last 2 weeks. So India is having a grim future, but I want to end with a note of hope, because in US, as we are striving into normalcy every day, then my country of birth is hit so hard. But I would quote a poem by Rilke, because life is like this. And I'd like to say that let everything happen to you, the beauty and the terror. We have to just keep going, because no feeling is final. And this will be over too for India. Thank you so much.
Wow, that was lovely. Thank you, Bhramar. That was really great. If you have questions, please feel free to enter them into the Q&A. There was a question about underreporting and excess deaths, but I think you've actually sort of answered that in the course of your talk. But if not, please, feel free to re-enter the question or add more detail. And maybe I'll start with a question of my own. I haven't been paying attention to time. I think we're okay on time. But so I was curious, like, given your estimates of ascertainment bias and underreporting, how close do you think India is with the severity of the current? I'm sure you get this question all the time. How close do you think India is to hitting herd immunity? What do you think is the story there? Yeah.
Yeah, I think that that's a great question because I myself am puzzled about this. The first wave, the sero surveys that came out of India are actually showed that in major Indian metros, more than like 1 out of 2 people were infected. So, for example, from Delhi, the latest sero survey was 56%. And still, and Mumbai was some of the areas were 60%. And those same areas, so Pune, for example, 75% seroprevalence, last seroprevalence survey, those areas were particularly hard hit this time. So it's very hard to explain what exactly is going on in terms of, reinfection and so on. So I think I feel like herd immunity will be a elusive short-term target for India right now.
Yeah, no, absolutely. I think that, and there's a lot of interesting questions there about, the sort of the network structure and connectivity of people and contacts and things like that.